From the beautiful Finger Lakes region of upstate New York, this is the Dental Lighthouse Podcast. We take questions from anyone in the dental profession and discuss what it takes to win not only in dentistry, but in life. Business, leadership, relationships, parenting, health and wellness, money management, nothing is off limits on the Dental Lighthouse Podcast. I'm Jason Tenori, your host, and have over 20 years of experience to pull from. Learn from my mistakes and let me help you collapse time so you can become the best version of yourself. Yo, what is up? Dr. Jason here at Dental Lighthouse Podcast. It is a beautiful Wednesday morning, February 4th. I actually had to put the blinds down in my office because the sun is blaring out of the east. Super snowy here, still single digit temperatures. And to be honest, it's getting a little old. But last night I was picking up my son, Luke, from swimming. It was about 6 o'clock and it was still a little bright out. So that's kind of nice. Couple things, little housekeeping here. I'm curious. I'm going to talk a little. I'm going to do kind of just a musing or a rambling or whatever you guys want to call it. I'm going to go off on a tangent about case acceptance. We've been talking about it a lot in our coaching group, and I just want to give you guys some nuggets today that I think can improve your case acceptance immediately. But I'm curious, many of the podcasts that I listen to have two people on them. It's somebody interviewing someone else, or there's a conversation or something like that. And then some of the podcasts that I listen to are single person, and some are a combination of both. So what do you prefer? Do you prefer when I bring on a guest and we have a conversation, like an expert, like Ryan Gross from CMO Share Marketing, or Scott Haberman, an accounting expert, Perrin Dusport's an M&A leadership savant, or do you prefer when I just kind of try to get real and talk practical and just kind of do some ramblings on my own? And I guess there's a third choice. Oftentimes we'll take questions from the listeners either live, or they'll shoot me an email or a text message, and then I try to answer them. So, I want to give you guys more of what you want, more of what you feel is creating the most value for you. So, shoot me a text, drop me an email, let me know, what you'd like to see more of. Is it more of the solo stuff? Is it more where I bring on an expert, or is it more when, I bring on everyday Joes like you and me and try to answer their questions? They're real life in the weeds. They're at the front lines of the battle. Try to answer their questions about different things. So today, again, I wanted to talk about case acceptance. It's been a real hot topic in our coaching group and with some of my one-on-one clients. And I'd like to just kind of do a brain dump on you guys and give you some things that I think will help you, like literally tomorrow. Some things that'll take a little bit longer to get the flywheel of momentum going. But if you incorporate some or all of these things, I can guarantee that you're going to get more patients to say yes to the treatment that you're proposing. Excuse me while I grab some coffee. So let's set the stage. What do we mean by case acceptance? So in my world, there's case acceptance and there's treatment acceptance. Case acceptance is the metric that we use routinely. We track routinely with all of our doctors. And we define case acceptance as dollars accepted and scheduled over dollars presented, right? Very simple formula. So if you present $10,000 of dentistry on a given day and $3,000 of those dollars gets scheduled, your case acceptance for the day is 30%. Treatment acceptance is a different metric that I'm not going to get into, and one that personally I don't feel holds a lot of value. So what is a good case acceptance? Well, if you're a general dentist and you're doing a lot of different things, it can range a tremendous amount. In my opinion, 30 to 40% for an associate-driven practice is a really good case acceptance. If you're the owner and you have a little bit more trust with the patient base, and you're the only provider, and things like that, the case acceptance should be a little bit higher than that, in the 40 to 50% range. Okay. So if you fall into those categories, great. If you don't fall into those numbers, great. It is what it is, but just wanted to give you guys some baselines based on my own lived experience. So these are going to be four, five, six things that I think will automatically take your case acceptance to the next level if and when you incorporate these things. And I'm going to mention some systems in here. I'm going to mention some visuals in here. If I reference that um, I have access to these things, or if you want access to these things, please hit us up. Reach out via our email address on the dentallighthouse.com. Okay. First thing is schedule appropriately when a patient calls, right? So what do I mean by that? Well, there's multiple ways for patients to get into the office. We have the patient that is new to the area, has been seeing a dentist every 6 months, and just wants a cleaning and exam. We'll give them that, right? Schedule them in hygiene for 90 minutes. Make it for a comprehensive exam and a prophy. Now, if they have periodontal, we go down that rabbit hole and we could talk about how we have to pivot. But if it's someone that's healthy and they know they're health, or they claim to be healthy, they think they're healthy, and they have a regular relationship, or they've had a regular relationship, just schedule them in hygiene. Don't schedule everyone in hygiene, but schedule that patient in hygiene. If the patient calls and says, I need a cleaning or I need a checkup, and you take it to the next level and you're start asking the right questions, and it turns out they haven't been to the dentist in 5, 6 years, they have some broken teeth, they had a bad experience, they're a little anxious, don't schedule them in hygiene for 90 minutes. Schedule them with the doctor, typically in a second chair. Those of you guys that follow my scheduling templates know that we have first and second chairs. You typically schedule them in the second chair, and you bring that patient back, and you're having one of your more tenured assistants who knows how to communicate to people manage that appointment, right? Um, if it's someone that's asking for a second opinion uh, on something, offer a second opinion. You don't try to rope them into a comprehensive new patient exam if that's not what they're looking for. And then finally, if it's an emergency, if they're in pain, if they're if they have a front tooth that's broken, schedule an emergency exam. Don't try to put everybody in a box where everybody needs 60 minutes with the doctor. If that's your philosophy, great. But as you scale and as you bring on additional providers, it's going to be hard to put everyone in that box. So the first piece of advice that I would give you is listen to the prospective new patient on the phone and schedule appropriately. All right, that's number one. Number two, don't overwhelm patients with choices and comprehensiveness. Now, I know what you're saying. Well, I'm a comprehensive dentist. I have to treatment plan comprehensively. Just hear me out, right? So, in the first part of this, don't overwhelm people with choices. It's like clockwork. One of the things I constantly see with our newer associates as we're going through the onboarding and as they're trying to become um, acclimated to what we do is they offer way too many choices to patients, sometimes four or five choices for one issue. And think about how overwhelming that is. Think about if your transmission blew in your car, or it started to make a noise, and you bring it to the mechanic, assuming you don't have any um, knowledge of the auto mechanic world. So you're kind of just going based off of trust. And the mechanic looks at it and he comes out. He says, "Okay, well, we have five choices. We can do this. We can do this. We can do this. We can do this. Or we can do this." I'm like, dude, like I have no idea what to do. Like, give me two choices. Tell me the best thing to do to fix it. And then if I needed to patch it up, or if I needed a short-term fix or a transitional fix, tell me that. And I think the same thing should be applicable in dentistry. Now, don't get me wrong. There's not going to, every single situation isn't only two choices. Some situations there's one choice. And in very, very rare situations, there might be a third choice. But, if a patient comes in with a premolar, um, broken cusp, borderline restorable. Stop with the endo buildup, crown lengthening crown. That's choice one. Choice two, extraction, bone graft, implant supported crown. Choice three, extraction, bone graft, three in a bridge. Choice four, partial denture. Choice five, like you're you're overwhelming people, and I can promise you, ask your treatment coordinator if you don't believe me. If you have a level of trust and vulnerability with your treatment coordinator, they will back me up here. Patients are saying no. Well, actually, they're not coming out and saying no. They're saying, let me think about it. Or they're saying, I'm not sure. Or they're saying, let me talk to my spouse because they're overwhelmed. They have no idea what they should choose. They didn't go to you simply for choices. They go, they went to you because you're an expert. And they need an advocate and they need someone to say, this is what you should do. Now, if you're a younger dentist, this can sometimes be hard, right? But even a younger dentist is an expert when compared to some of these patients, right? So what I would strongly encourage you to do is diagnose the condition, diagnose what's going on, and simply give two choices. In my world, I'm saying something like, Mrs. Jones, this is what's going on. If you want to fix this the best way possible, the best way that we have available to us now, this is what you should do. If that doesn't work to you because you don't value the treatment, you can't afford the treatment, your insurance won't pay for that treatment, then a secondary, albeit not as good option, a transitional option would be this. The problem that we have with the transitional option is we're going to be revisiting it in a few years. But if that's what you want, then that's what we can do. So I'm going to have Michelle at the front desk talk to you about the ideal way to fix it and then a compromise. Do you have any questions about that? That's all you need to say. And I can promise you that when you narrow down your choices to those two, you're going to start to get many more people say yes. Now, they might say yes to optimal and they might say yes to the transitional temporary work, but at least you're going to get the patient to say yes and you're not overwhelming them. The second part of this is overwhelming people with comprehensiveness. Now, again, I'm a 100% advocate for comprehensive dental care. But going back to our first point about listening on the phone and scheduling appropriately, if the patient just wants an opinion on one area of their mouth, then do a limited exam or do a consult and give them a treatment plan for one area of their mouth. If the patient's coming in for a comprehensive exam because they don't have any immediate issues and they want to have a look at everything, you as the dentist or your assistant have to have a conversation with them and you have to be able to read the room. So even saying things like, Mrs. Jones, there's a lot going on here. Do you want me to document everything and present to you a plan that covers everything to fix your mouth ideally? Or do you want me to focus in on one specific area and just talk about that with you today? And whatever she says is the direction that you should go. Now, if she says, I want to focus in on one specific area, I'm not suggesting that you don't treatment plan comprehensively. Okay. So you need to document existing and then you need to document the comprehensive treatment plan. I'm just not presenting the comprehensive treatment plan. I'm only presenting a quadrant or an arch or the primary need or the what's most important right now for this particular patient. Now, I know there's people out there that are going to argue, well, that's not the right thing to do. Let's agree to disagree, because kind of going back to the point about choices and being overwhelmed, I have just found that when someone comes in and they know they need a lot of work, but there is a specific area that they want to focus on, and I talk them into or strong arm them into hearing everything, they get overwhelmed and then they ultimately have to think about it or they're not quite sure or what have you. So treatment plan comprehensively, but ask the patient or get an idea from the patient on if they want the full comprehensive treatment plan presented to them or if they want to go bit by bit, tooth by tooth, quadrant by quadrant, whatever it is. Now, obviously, let's state the obvious here. There's some situations where you can't treatment plan. You can't execute a treatment plan piecemeal because there's occlusal issues or there's something else going on. I get it, right? But I also will suggest that there's many different ways to phase comprehensive treatment over time for patients, especially now with 3D printing, thinking outside the box, You can do it. Um, Next thing I want next point I want to talk about is talk about some basic things coming out of hygiene, right? Most of our dentistry, most of our restorative dentistry is going to come out of hygiene. So how do we figure out a way to get the patients out of hygiene that need the work, right? We're not talking about making up uh, treatment plans here. These patients need the work. How do we get them to say yes and get into your restorative chair? There's a couple things that I want to talk about here. First thing is the hygienist needs to use pictures. Okay. It's one thing to verbally explain periodontal. It's one thing to verbally explain cracks and marginal ridges. And it's one thing to explain stain grooves and all of this stuff. I've done it before this way, right? It's exhausting to try to explain this to patient. You start using your hands and you're making a fist with your right hand and then you're cupping your left hand and you're putting it over your fist like, oh, like a crown, like this. They have no idea what you're talking about. Okay. I'm telling you this. They have no idea. So you start to use pictures and you don't need to go into a whole, extensive photo library. Take a couple intraoral pictures, or better yet, um, take a iTero scan, a wellness scan, take a quadrant photograph, take an arch photograph, and the resolution of these cameras now are so amazing. Even with an iPhone or a smartphone, you can blow it up on a screen that's in front of the patient. You can take an arch picture and blow it up and see one or two teeth. So use visuals to educate the patient as to their current condition or what they need. Stop trying to explain it verbally. I can promise you that what you're saying sounds like a foreign language to the patient. Okay. There's other no, sorry, verbal. There's other pictures, visuals that you can use that our organization uses that are tremendously successful. One is a great picture, and I'll send it to you guys if you reach out and you want me. I got it from Chris Phelps and made some edits to it, but it's a cross-sectional picture of a tooth with decay starting at the enamel, then getting into the DEJ, then getting close to the nerve, then getting into the nerve. And there's an associated dollar sign with every level of decay. So the decay that's just into the DEJ has like $1 sign. The decay that's halfway through the DEJ has $2 signs. The decay that's into the nerve has $3 signs. That's common. Like people get that. It's like when you Google a restaurant, hey, you're restaurants near me, and all of a sudden the dollar signs come up. People automatically know that if it's $1 sign, it's probably low quality, fast food, right? You can explain to the patient when it's $1 sign, hey, your cavity is small. This is a small issue. It'll never be less expensive than it's going to be today to fix this. I would strongly encourage you to do that. If we don't fix it, then it's going to turn into this. And you show them $2 signs, the $3 sign. People get visuals, so use them. A final visual that we've been using that I think resonates really well, and I'm not suggesting you run out and do this. Actually, I'll go over two more visuals. One is using AI. We currently use Overjet. I know there's Pearl, stuff like that. But showing a patient a black and white radiograph and then trying to show them the gray or different opacities of a cavity, radiolucencies of a cavity, it's tough to see. I didn't really get it until I was like a third year dental student. Maybe it's just because I'm incompetent, but it's hard for patients to see that. So with something like Overjet or Pearl, and I know there's a handful of other ones, you click a button and all of a sudden the cavity's red, right? So he's like, look, here's the nerve, which is clear. You can see this H-like thing is the nerve in your molar. And this red right here is the cavity. See how close the red is to the nerve? That's an issue, right? Do you have any questions about that, Mrs. Jones? No. So that's a great visual to use. Another visual to use, again, this is a little bit further along, is for periodontal disease, is using the microscope. Now, I'm not going to get on a soapbox and tell you use the microscope, don't use the microscope. But the hygienists that we have that routinely use the microscope for patients that are borderline periodontal disease or even full-blown periodontal disease, from the moment they decide to take a sample from the patient's mouth to the moment it's on the screen is 3 minutes. Okay. So how long does it take for you, assuming you don't have trust with this patient, how long does it take for you to talk about probing depths, bleeding upon probing, um, infection, drainage, separation, bone loss, all of these things, right? Like it's a foreign language to the patient. But when you can pull up on the television screen in front of the patient and they see a spirochete flying around the screen or an amoeba flying across the screen, I promise you that they're like, okay, what do I need to do to get rid of that? So these are great visuals. These are great adjuncts to help the patient to get to yes. Now, again, I'm not saying go out and get a microscope. I'm not saying go out and get clinical AI software. Take a photograph with your iPhone, with a smartphone, right? Have a couple visuals on the wall. It will help you with your case acceptance. I want high, so that's the third thing or fourth. I don't even know where we're at. I'm just going to go down my list. The next thing I want to talk about is the hygienist preheating the patient and the doctor being the second opinion. So let's unpack what that means. The worst thing ever is when you come into a recall exam, it's 45 or 50 minutes into the appointment, there's 10 or 15 minutes left, and um, you get a decent handoff from the hygienist. You sit down and you look in the patient's mouth, and the first thing you see, just because you have this gift, is there's a broken lingual cusp on 30. And I'm sorry, on 3. And you're like, Mrs. Jones, when did you break this tooth? And she's like, what? I broke a tooth? She has no idea, right? That's wrong on so many levels. First, and I can guarantee you in her mind, she's thinking, what's going on? Like, I've been with Mary, my hygienist, for the last 45 minutes and she hasn't said anything. So all of a sudden there's doubt. So I always want the doctor to be the second opinion. So we have to train our hygienist. Now, don't get me wrong. I want my hygienist to be social and cordial and ask about their family and their profession and stuff like that. But the patients can get that at their Friday, dinner dates and their book club winery thing, whatever they do, right? Or my wife plays a lot of pickleball. She can get all of that conversation there. These patients go to the dentist ideally twice a year. We need to spend a good amount of that time educating the patient as to what's going on in their mouth and striving for better oral systemic health. So if they have something going on in their mouth, even if the hygienist is not really sure, like they have to preheat the patient. They have to say something along the lines of, Mrs. Jones, this tooth on the upper right appears broken to me. I'm not 100% sure, but I'm definitely going to have Dr. Jason look at it. Or Mrs. Jones, which appears to be a fairly large crack in this lower molar. Are you having any problems with it? Were you aware of it? No, I had no idea. Well, just a heads up, I got a feeling that Dr. Jason's going to talk to you about it. I'm not sure exactly what his treatment recommendation is going to be, but this is definitely a concern. That's what we call preheating the patient. Okay. So then the doctor walks in, there's a handoff, right? In our world, there's a couple of things that we need to do in regards to the handoff. The first thing is making sure the hygienist communicates to the doctor who this patient is and if they've seen them before. There's nothing worse, ask me how I know, there's nothing worse than the hygienist giving a crappy handoff. And then I walk in the room and say, hey, nice to meet you. Good to see you. And the patient's like, nice to meet you. You did a crown on me 6 months ago. I'm like, oh. So the hygienist has to say, hey, Dr. Jason, you remember Mary, you did that work for her on the upper left. She says it feels great. I just need you to look at the lower right. Looks like she's cracked something there. She's unaware of it. I'm a little concerned. Hopefully it's nothing, but I want to make sure that you look at it. Right. So now what we've done is we've made sure that the doctor knows if they've met this patient before or not. That's the first thing. The second thing that we've done is we've preheated the patient already in the hygiene room without the doctor. And then the patient heard it again during the handoff. And now I'm going to be the second opinion. I'm going to sit down and I'm going to say, Hey, great catch here, Mary. There's a pretty big crack here on the distal margin of the ridge. Um, this is something that we really need to get taken care of before it fully cracks and it turns into a root canal, or you can't, or we can't save the tooth. And then we kind of go into the education, maybe take a picture or something like that. Again, preheat. Make sure that when we're doing the handoff, we tell the doctor if they've met this person before or not, and then the doctor's got to be the second opinion. Um, I love to talk about what we call the other side of the problem. Okay. There's always an other side of the problem, right? So when we have a patient come in and we see decay, interproximal decay that's a couple millimeters into the DEJ, can be fixed with a filling. Okay. Mrs. Jones, there's some cavity here. It's not too bad, but it's bad enough where we really need to get it taken care of ASAP. I just need you to understand that if we don't take care of it, now, this is the other side of the problem. If we don't take care of it, this is going to turn into a root canal, or this is going to turn into a root canal and a crown. Now, I can't tell you exactly when that's going to happen. It ultimately depends on how fast this decay develops in your tooth. Again, I'll reference that picture that I showed or that I just described regarding the dollar signs, but try to take care of it as soon as you can because I don't want you to have to deal with. Now, again, I wouldn't say the other side of the problem, but that's what we're talking about here. Please get it taken care of as soon as you can because I don't want you to have to deal with a root canal. I don't want you to have to deal with um, a crown, right? You could use the other side of the problem in literally every situation, right? Someone has mild to moderate periodontal. Mrs. Jones, as Mary has been talking to you about and is showing you with the microscope or this, as you can see, this photograph of this tons of bleeding and inflammation that you have in your mouth. And I know that Mary's talked to you about the oral systemic connection. We would strongly advise you to go through some non-surgical periodontal therapy. It's really the best thing for you to take care of this. You go whatever your spiel is for that. And then what's the other side of the problem? And I also wouldn't be doing my job if I didn't tell you that if we choose not to do this, if you choose not to be proactive and take care of this now, what's most likely going to happen is we're going to have to refer you to a periodontist for gum surgery. Nobody wants to go through that. But if we don't deal with this in the near future, you're almost destined to have to be sent to the periodontist and have gum surgery. It's your job to talk about the other side of the problem. Too often we say, this tooth needs a crown. Take care of it when you can. No big deal. Call me when you're ready. That's like, can you imagine if you rolled into the mechanic with four bald tires and the mechanic's like, you need some new tires, but whenever you're ready, take care of it when you can. And then a week later you blow a tire. Like you have a right to be mad at the mechanic, right? Because they dismissed the urgency that's associated with what you have going on with the car. So don't be dismissive of what's going on. Like talk about exactly what is going on. Talk about how this will never be less involved and less expensive to fix than it is today. And then talk about the other side of the problem. Now, you can also say, I can't tell you how long, but I can promise you that this will eventually turn into endo buildup crown. Or if they need a root canal, this will eventually turn into a tooth that's not fixable. We're going to have to put an implant in. Or your bite is so traumatic that this will eventually lead to broken teeth if we don't consider Invisalign. Like there's always, always, always another side, the other side of the problem. I got a couple more that I want to talk about. I could talk about case acceptance all day. I absolutely love it to death. And hopefully some of these nuggets are helping you. Create urgency. So again, let's stay in the hygiene room. Earlier in my career, I would diagnose a problem. I would come up with a treatment. And then, like I alluded to a few seconds ago, I would not create any urgency to get it scheduled. I would say, yes, try to get it taken care of before your next cleaning appointment, or, take care of it when you're ready, or what have you. And again, the reason I did that is fear of rejection, right? I didn't want the patient to be upset with me. I didn't want the patient to um, feel like I was pressuring them. And as I've gotten older and arguably a little bit more wiser, I've come to the realization that I'm the expert. Again, I'm not saying this with as little ego as possible. I'm the expert. I'm the one that went to all that schooling. I'm the one that researches and gets better every single year on the newest techniques and what's going on in this profession. Patients come to me for my expert opinion. So for me to be worried about how my expert opinion is going to be perceived is bullshit. You go to your primary care physician and they do some blood work and you have super high cholesterol, blood pressure's up, and you're pre-diabetic. How many of your doctors are being like, you know, sometime over the next 6 months, I'd probably get on a statin. I would, when you're ready, start trying to reduce the sugar. It's ridiculous. They would never, they're like, they're creating urgency. They don't care how you receive this information. Now, again, they're trying to do it as empathetically as possible if they're a good physician. Many of them out there are not. That's a story for another day. But like, they're telling the patient what they need to do right away. Why are we not doing the same thing? So make sure you're creating a sense of urgency. One of the things that I love, and I stole this from Cure Dent, and we've kind of put our own spin on it, is every router has the acronym NDTR. N stands for next appointment. So what is the next appointment? Let's say we're doing a recall appointment in hygiene. The next appointment for Mrs. Jones is that buildup and crown on tooth number 30. Okay. D stands for due. When is it due? What is the date that I can get this scheduled? Okay. This is where we get away from the ambiguity of when should this next appointment be. And I'll share with you that at morning meeting, what you should be doing is going over your schedule and making sure you have clarity on when your next available appointment is. Because if your next available restorative appointment is in 2 or 3 weeks, and you say to Mrs. Jones, you need to get in ASAP to get this taken care of. I'm really worried that this is going to break. Okay. And Mrs. Jones is like, hell yeah, I need to get it taken care of. She gets to the front desk and the hygienist communicates to the TC, hey, doc wants Mrs. Jones to get in for this ASAP. It's about to break. And then the TC says, my first available appointment is in 3 weeks. Like, you want to talk about someone that's going to be really upset at the front desk? And it's your fault, right? Because you threw out ASAP without having any clarity on when your next available appointment is. So at morning meeting, you should really start to think about, okay, when can I get these patients in? And if it's 2 weeks, then you say to the patient, Mrs. Jones, this needs to build up and crown. I would definitely try to get this taken care of within the next 2 to 3 weeks. Okay. Otherwise, the other side of the problem. Okay. Now, if you have an appointment tomorrow and you discover that in morning meeting, then I would say that. I would say, Mrs. Jones, we need to get this done right away. I could probably move some patients around tomorrow to make room for you. I just don't want to see you bite into something just the right way and split this tooth in half. Like, that's how you should ultimately handle it in terms of creating urgency for the patient. And then once you create the urgency, being able to accommodate the patient accordingly. Where we're all guilty of this is with periodontal disease. Okay. Those of you guys that don't use block scheduling for scaling and root planing, you spend anywhere from 5 minutes to 20 minutes educating your patient on the periodontal disease they have, what it's doing to their oral systemic health. They completely understand what you're saying. They've seen the microscope pictures. They've seen the bleeding upon probing photograph, or they're holding a mirror. And then they get to the front desk and the TC says, our first available appointment for this is in 4 months. Like, what? Like, you just educated the patient how severe this is, how much of an urgent matter this is, and you can't get them in for 4 months. That's a shame on you type of situation. And you need to be doing some things accordingly that prevent that conversation at the front desk from having. Again, conversation for a different day regarding hygiene blocks, but just keep that in the back of your mind. The last thing I'm going to talk about with case acceptance is ballpark fees. Now, again, I can hear some of you doctors saying, well, I'm the doctor. I don't talk about money. I get it. Right. And I'm not even talking about like if it's a crown or a root canal or something like I'm talking about like when a patient comes in and there's some needs here, right? And we see a lot of patients who have, let's call terminal dentitions, right? They've avoided the dentist for a long, long time, typically metabolically unhealthy, raging perio, or maybe a drug addiction that led to teeth that are no longer restorable. And in our world, there's basically three choices for these patients. There's immediate dentures that are not implant supported. There's immediate dentures that are implant supported. And then there's screw retained bridge work that's implant supported. Those are the three choices. Obviously, there's nuances in there and what have you, but you want to talk about a huge waste of time and you want to talk about making patients feel very, very small is you start talking up a specific treatment because the patient's like, this is what I want. And you talk it up, they get excited, and then they get to the front desk and they realize that this treatment plan is 40 to $50,000, and all they have to spend is $4 or $5,000. So in order to avoid all of that headache, all of that embarrassment, all of the work that you put in with entering the treatment plan, presenting treatment, you really need to do two things. You need to get a little bit of clarity from the patient on what they truly want. And then once you do that, you need to give some ballpark fees. So how do we ask patients what they truly want? Well, simple questions like, you know, Mrs. Jones, it doesn't look like we're going to be able to save any of these teeth. I'm assuming you realize that. Is that in fact the case? Yeah, I know. I went to a dentist a couple of years ago and they kind of mentioned that. So, and it's only gotten worse. So I know I'm not going to be able to save any of my teeth. Okay, perfect. Mrs. Jones, have you thought about how you want to replace your teeth? Or asked another way, are you going to be okay with teeth that come in and out at night, like a denture? Or are you going to insist on teeth that stay in your mouth permanently, that are permanently screwed in? Oh my gosh, I would never, I can't imagine having teeth that come in and out. So they absolutely have to be screwed in. Oh, perfect. I'm glad that you have clarity with what you want. I want you to look at some of these photographs, and we have big laminated pictures, and we would break out the screw retained bridgework photograph. And I would say, this is what we're talking about. We have many, many patients that do this treatment. It typically takes about 6 months. Patients are extremely happy. The biggest disadvantage with this particular option is cost. As you can see here, for just the upper jaw, it's about $20,000. For the lower jaw, it's an additional $20,000. So all in, we're looking at $40,000. Now, I don't want to make any assumptions here, but if this is in fact what you want, let's continue to move forward talking about this particular option. Oh my gosh, I had no idea that it was going to be that expensive. I thought my insurance was going to cover this. Well, I'm glad that we're having this conversation, Mrs. Jones, because the last thing I want to do is waste your time and energy talking to you about something that might be out of your budget. So if this option is not viable for you, let's talk about the other two options, either a traditional denture that floats around in your mouth that is not supported by implants, or dentures that are secured by either 2 or 4 dental implants. Let's talk about those, and I break out the picture, and we'll talk about, again, I'm not talking about specific costs, but I'm giving ballpark ranges. That I have found has been extremely beneficial to develop trust and honesty and some transparency with the patient. One final bonus note here with these types of cases is if you can get the patient to bring an advocate for them. So typically it's a 50 or 60-year-old. If you can get them to bring their spouse or their son or daughter, or if it's a younger person and to bring their mom or dad, only every single time you'll get treatment, you get case acceptance to increase. So if they come by themselves and you could kind of read the room and you could kind of tell that they're unsure and that blah, 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 in my mind, I take a time out and I say, Mrs. Jones, there's a lot going on here, and I would be doing you a disservice if I only spent 5 or 10 minutes with you looking at your x-rays, looking at your photographs, and come up with a plan that's perfectly customized for you. I'm going to ask your permission that I take the records that I need now, the photographs and the x-rays and the scans. I'll come in this weekend. I'll review your case. I'll learn it inside and out by heart. And I would love for next week or in a couple of weeks, you come in and we can go over what your options are. But I would love for you to bring someone that you trust, either or a parent or a good friend, a son or daughter, because we're going to be talking about a lot of information. And I would love for you to have a second set of eyes and ears on the conversation. Is that something that you're open to? I've almost never had someone push back on that. So when you do have that patient come in 2 weeks from now, this is almost always how it plays out. You kind of go over the two options, or again, we don't want to give multiple options. You go over the two options for this patient. And then the person that's sitting in the corner of the room, the spouse, says something like, Mary, you've been talking about your teeth for like 4 or 5 years now. Like, it's time to get something done. We're here because we trust this office. Our neighbor just had work done here and can't stop raving about it. So it's a lot of money. Yeah, but we gotta solve for this problem. We can't continue to deal with what we're dealing with. Let's move forward with this. And that's how it plays out. So again, I hope these nuggets, these pearls, these whatever you guys want to call them, were beneficial for you. They're things that I've developed over time that I try to teach my associates in order to get them to get more yeses out of the patients. If you have any follow-up questions or concerns, you want to hop on a podcast and talk it through, or just hop on a phone call and talk it through, don't hesitate to reach out to me. Like I said, my contact information is on dentallighthouse.com. I'd love to hear from you. And again, if this content is good for you, do two things for me. Share it with a colleague that you think might be struggling with case acceptance. Share it with one of your associates that you think might be struggling with case acceptance. And then please leave me a review. If the content's good and you feel like I'm making a difference and helping you get to the point that you want to be, collapsing time for you, I would so appreciate a 5-star review. The more of these positive reviews I get, the more my content can get in front of other people. And that's ultimately what my goal is with this podcast, is to just collapse time for other people, share some of the wisdom that I've accumulated over 25 years in an effort to make your journey a little less difficult than mine was. So thanks, guys. Love you. Have a good one.
Thank you. That wraps up another episode of the Dental Lighthouse Podcast. You have a choice today. Choose to be a lighthouse. Lighthouses are powerful and steadfast. They are beacons of light for others to reference when life gets turbulent. Go out into the world today and become a lighthouse for someone. Give more than you get. True joy comes from serving others. Start today. I'm Jason Tenori, your host. Thank you for listening to the Dental Lighthouse Podcast. For more information, podcast show notes, or links to anything that we have discussed today, please check out our website, thedentallighthouse.com. We would love to hear from you. If you would like to get on the show, please email us at podcast@thedentallighthouse.com.